Hi, my name is Philip Araoz. I'm a radiologist at the Mayo Clinic, and I'm going to talk to you about lateral chest radiograph mediastinal anatomy. And here's a lateral radiograph. And I'm going to overlay a little bit of some lines to show you where the structures are and to show what structures we're going to go over. This is the trachea. And we're going to go over the right upper lobe bronchi and left bronchi, which in most patients might be the left main, but it might not be. We'll get into that. Right here is the right upper pulmonary vein and the interlobar pulmonary artery. Actually doesn't show up in this particular radiograph, but I'll show you some where it does. The left pulmonary artery lives here, and it usually doesn't show up on a radiograph, but I'll show you some examples where it does show up. The pulmonary veins are about there. Esophagus is back here. This is where the left atrium is, and the left ventricle, the pericardium, the Rvl Flow, and the aorta, and we're going to mostly talk about the ascending aorta. So we're going to overlay, so here's the trachea, this is where the trachea is, and we're going to overlay a CT scan taken from the same patient, and we're going to peel away and kind of scroll to the midline. So there's the left ventricle coming into view, here's the ascending aorta, and we come to midline, and here's the trachea just anterior to the spine. And you can see in this patient there's soft tissue, this little piece of soft tissue, which in this, the way it's laid out here is kind of pink, is the esophagus. So when we look from the lateral view, there's the trachea, right behind it's the esophagus. And if the trachea has soft tissue behind it, as in this patient, you won't see the posterior wall as a distinct line. You'll see darkness where it says the air-filled trachea, and you'll see whiteness, which is the soft tissue. Note that normally behind the trachea, there's a little soft tissue. The esophagus, there's little soft tissue. The esophagus sits there, but little else. So normally you have the esophagus there, but not much else. Also note the trachea is set off slightly to the right. That's because the aortic arch normally will sort of displace the trachea a little bit to the patient's right, which is our left. And the more it's displaced to the right, the more likely to see the posterior wall, because you're more likely to get a little bit of air creeping back here. And if you have air behind the trachea, you'll see the posterior wall as a line. So we're going to take the CT scan and slowly rotate around to the front. We get the aorta coming into view. Here's the left atrium. Here's the trachea, and there's the left main bronchus, right pulmonary artery. We overlay the frontal radiograph, fill in a little bit. And there we go. So there's the trachea. There's a border between the dark and light in this patient. We see sort of a block of gray or an edge. We don't see a straight line. And that's again because there's no air posterior to the trachea in this patient. We take a different patient, which is a 65-year-old male, and you look back here, and now you can see that there is a distinct line, kind of a thick line posterior to the trachea. There's a line posterior to the lumen of the trachea. And in this patient, the reason we have it is because there's air posterior to the trachea, which is here. So there's this air, and so we get this soft tissue and a little bit of the subclavian artery make part of this line, and posterior to this, right back here, we have air, and that's what makes a line. A different patient, 57-year-old male, we see a line here, a clear, sharp line posterior to the trachea, and the reason is because this person's trachea is offset slightly to the right, and this little piece of lung sort of invaginates back there, and that's why you get a line on the lateral radiograph. Okay, here's a different patient, 79-year-old female. Here you can see the trachea, you see it there, and it's bowed anteriorly. There's anterior displacement of the trachea. And what's causing that? Well, look through here, you can sort of see that there's a little circular opacity posterior to the trachea. There's even a little fleck of calcium. So if we go to the CT scan and we peel away and we go to the midline, there's the aorta. And coming off the aorta is this is a big blood vessels, a big artery. And this is an aberrant right subclavian artery. Normally, the aortic arch has three great arteries, the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. You can have variant branching where you have four great arteries and the right subclavian artery comes off as a separate branch posteriorly. If we rotate around to the front, you can see that there's the right subclavian artery coming off there. And if we fill in a little bit, we'll fill into the frontal radiograph. Here it is, there it is. So that bump is the aberrant right subclavian artery. And this lucency on the chest x-ray comes from this air behind the descending thoracic aorta. And if we overlay the 3D, you can see there's the ascending aorta, the arch, and the descending thoracic aorta. And this artery coming in the back is coming posterior to the trachea. It's what's causing the displacement of the trachea in the lateral radiograph. If we do a 360 rotation, there's the aortic arch, and right there is our aberrant right subclavian artery, right here. And again, it's running posterior to the trachea. And in this patient, it's what's causing their bowing and displacement on the lateral radiograph. So let's move down here to the right upper lobe and left bronchi. So if you're looking on a frontal radiograph, we can see that this is the way that bronchi normally go. There's the trachea, and this short little stem here is the right main stem. And then once it gives off this bronchus, this is the right upper lobe bronchus. Then this changes, this is no longer considered right main stem. This is now called bronchus intermedius. But the point is, this is the right upper lobe bronchus. And it runs mostly in the left to right, sort of in this plane, which is why you see it end on as a circle. On the other side, we have this long left main bronchus. And so if you look about here, you can sometimes see the left main bronchus itself, or one of its branches, the left upper lobe or left lower lobe branches. If you're looking from the side, you'll see the right upper lobe bronchus end on, and one of the lower lobe bronchuses end on. And notice how the left pulmonary artery goes over the main bronchus. We'll get into this more. And that's one of the reasons the left main bronchus is more inferior than the right. Well, the left upper lobe bronchus is more inferior than the right upper lobe bronchus. If we fill in the CT scan to sort of show that anatomy, we can see trachea, the left main, and the right upper lobe bronchus. So this is the axial CT scan from the same patient. This is this level right here. This is the right main stem. That's the right upper lobe bronchus. And you can see the right upper lobe bronchus runs almost in the axial plane. It runs almost straight left to right, which is why you see it end on as a circle. If it's very angulated, the way it is in some patients, if it's sort of angulating sort of more up and down, you won't see it as a discrete circle on the lateral chest X-ray. Now, this is a little slice more inferior on the same CT scan level down here, looking at the left. And in this patient, the more inferior circle is the left lower lobe bronchus. This bronchus is going posterior, and this back here is the left lower lobe. So if we look at, and that's why the lower bronchus is slightly posterior to the right upper lobe bronchus on the lateral in this radiograph in this patient. So there's the right upper lobe bronchus. It's a little more anterior. And this is the left lower lobe bronchus. And because the left lower lobe is a little more posterior, this one's a little more posterior. But that's specific to this patient. In other people, you might see the left main bronchus, and it'll be a little different. So there's the right upper lobe bronchus. There's a left lower lobe bronchus in this patient. And in this patient, you can see the left upper lobe bronchus, which is here. It's slightly visible on the lateral, use your imagination there, but not as clearly as the left lower because it's not as big and it's not as directly in the left to right plane. So you may see in a given patient, the left lower lobe, the left upper, or actually the left main itself before they bifurcate. And so in this patient, in some patients, the left upper lobe or the left main may be more visible. And remember that the left upper lobe is more anterior to the left lower lobe. And so its bronchus is going to be more anterior. This is supposed to be the left upper lobe, the left lower lobe overlaid on the chest X-ray in this patient. That's why the left main bifurcates, and the left main bifurcates anterior posterior. So you can think that's why the left upper lobe bronchus is anterior and the left upper lobe is more anterior and the left lower lobe is more posterior. Okay, we're going to rotate this CT scan around to the lateral. And you can see right there, this is the left lower lobe bronchus end on in this patient. Okay, this is a different patient, a 57-year-old female, status post bilateral lung transplants. So the lungs this patient now have came from somebody else, and they had to be sewn in and attached to her native bronchi. And so where her bronchi were sewn into these transplanted lungs, she had a bunch of strictures at these bronchial anastomoses. So she got stents placed to her left main bronchus here, going into her left lower lobe bronchus there, with the branch to the superior segment of the left lower lobe there. And we can zoom in on there. So these are stents in the bronchi. And the point of this is to show that, to make it clear where the bronchi are in the radiograph. This structure here is a stent in a pulmonary artery. But anyway, that's a left lower lobe bronchus. There's also a left upper pulmonary artery stent, because she also had pulmonary artery strictures where her native pulmonary artery got sewn into the pulmonary artery in the transplanted lung. So if we go to her CT scan and we kind of peel away to all these structures, you can see there's a stent in the left main bronchus. There's a stent in the left lower lobe. There's a stent to the superior segment left lower lobe. And there's also a stent in the left pulmonary artery there. Okay, so these are the bronchial stents. This is the pulmonary artery stent. Fill it in, rotate around. There's the bronchial stent. There's the pulmonary artery stent. We fill in. There we go. So this is a 58-year-old female. We can see this. There's the trachea. I'll show you again right there. And we only see one bronchus. Look again here. So we see one bronchus. We see a little bit of bowing of the trachea. Anterior bowing of the trachea. Only one bronchus is visible on this lateral radiograph. There's a circular or a suggestion of a circular opacity here, which is displacing the trachea. So we look at the frontal radiograph. There's something, this hilum isn't really normal. Let's explain why. First of all, the trachea and the carina are distorted, sort of flattened out. Normally the right mainstem bronchus is shorter and the right upper lobe bronchus comes out here, and the left lower lobe bronchus gets displaced inferiorly because there's a pulmonary artery running over, so this is distorted. There's a downward angle of the hilum, and you can see the superior border of the left main bronchus. Now, you normally don't see that because the left pulmonary artery is touching the superior border of the left main bronchus, which means that you don't normally see that line. So normally this touches the left pulmonary artery and it doesn't make a clear line. We go to the CT scan to see what's going on. We can see that the pulmonary artery, the left pulmonary artery, instead of going over the left bronchus as normal, is passing behind the trachea. And this is a condition called a pulmonary sling, where the left pulmonary artery passes posterior to the trachea. We rotate around to the lateral. We can see what's going on, that the pulmonary artery was causing this circular opacity and causing this displacement of the trachea. All right, moving on. Next, we're going to talk about this area. This is where the right upper pulmonary vein and interlobar pulmonary artery live. Now, this particular patient that we're using for most of our examples, we don't really see an opacity here, but we'll show you other patients where you do, and just to emphasize it's a normal structure. So the right upper pulmonary vein and the interlobar pulmonary artery. So what are those things? Well, let's peel away to the lateral. And as we peel away to the lateral in this patient, this is the same CT scan in the same patient. Here's the heart beating. Here's the ascending aorta. And now right behind the ascending aorta, this is the right pulmonary artery. And notice how the right pulmonary artery runs right to left through the mediastinum. So we're at a level about here, posterior to the ascending aorta. And the right pulmonary artery is running right to left. So there's the right pulmonary artery. There's the right pulmonary artery. And again, here at this level, you're going to have, if you have soft tissue posterior and you have the ascending aorta anterior, this won't make a discrete circle. So in the midline, the right pulmonary artery runs posterior to the aorta, like we're showing here. There's the ascending aorta. However, at this level, the right pulmonary artery, this thing is not going to be visible on the lateral chest X-ray due to adjacent soft tissue. In this case, there's no lung posterior here because usually there's esophagus. Now, this patient also has a little bit of adenopathy, which is another reason why we're not going to see this combination. That we're eventually going to look at is the combination of this pulmonary vein and this pulmonary artery together are going to make a little circular opacity that you frequently see on a lateral radiograph, though not in this patient. So we're going to move out laterally. Moving slightly to the right of midline, we're about here. And now this is the superior vena cava. You can see the contrast flowing into this is the right atrium. This is the left atrium. And we have these two circles here, which is our pulmonary artery has branched into made two bifurcation like that. The main pulmonary artery, the right pulmonary artery, has branched. We made a branch here between upper and lower branch. So there's our upper branch, there's our lower branch. Here, the right pulmonary artery bifurcates into the truncus anterior, which is this top guy, and the bottom guy, there's that guy. And then this bottom trunk is called the interlobar pulmonary artery. So, and it's right there, okay? And notice in this patient, there's this lymph tissue posterior to the right pulmonary artery, so it doesn't make a clear circle on the lateral radiograph. But if we were out a little farther, and if we didn't have this lymph tissue, we would have some structures here that would be surrounded by air, which would make a circle. And I'll show you other patients who have that. So if this patient, lymph tissue posterior to the interlobar pulmonary artery, which is the lower branch of the right pulmonary artery, decreases contact with the lung. Okay, that's why the interlobar pulmonary artery and this right pulmonary vein in this patient don't show up on the lateral radiograph. See, maybe there's a structure here. It's not very well demarcated, but this is what we're looking at. And we may see it in other patients, and I'll show you somebody else. So here's someone else. Now here, there's a little bit sharper, distinct circular opacity in this neighborhood. Again, we still have our trachea. This has a line. You can see there's a right upper lobe bronchus and a left bronchus, probably left main bronchus. And right out here in front of it, we have something that you could almost draw a circle around. We have a well-defined opacity in the expected location of the interlobar pulmonary artery and right upper pulmonary vein. And we'll show you what's making that circle in this patient. So we're going to go to a level just right of midline. So here we are scrolling from the left. Here's this patient's heart, ascending aorta, and right here, we're at about this level. We have right pulmonary artery, right there. There's no lymph tissue posterior to the right pulmonary artery. Now we're just going to go a little bit further to the right of midline. The right pulmonary artery hasn't bifurcated yet. If we go out a little further to the right of midline, there's the SVC. And we're going to get this little shape here. So this is the level of the right upper lobe bronchus origin, about there. We have the interlobar pulmonary artery, which is this circle, which is one of the branches of the right pulmonary artery. It doesn't show up on this so much. And right in front of it, we have the right upper pulmonary vein, which is this guy. And we'll see more about that. But basically, the upper pulmonary veins run in front of their pulmonary arteries. And together, these guys are out far enough lateral. There's the right upper pulmonary vein. This is the pulmonary artery we're talking about. These two together are surrounded enough by a lung. They're far enough out in the lung that on a lateral radiograph, they'll make a nice little circular opacity. They make a well-defined contour surrounded by lung. So here is the first patient we had, the standard patient we're using for most of our examples. And here is the second patient we just showed. And here we see a nice circular opacity. Here, because of this patient's anatomy and some lymph tissue, we don't see much of a circular opacity, but we see one here. Different patient, 64-year-old female. And again, we see a nice, well-demarcated opacity here in this patient. Person has an aortic valve replacement. Here's our trachea. Let's look there. If we go out laterally, this is our pulmonary artery, our interlobar branch. It's a branch of the right pulmonary artery. And in front of it, we have the right upper pulmonary vein. These two guys together make that opacity on the lateral radiograph. And we're at a level about here. So here's our interlobar pulmonary artery. And that little circle is the right upper pulmonary vein, which, as you can see, is running superior inferior. Together, they make a little opacity that you can see on a lateral radiograph out here. Different patient, 57-year-old male, and atrial fibrillation. Again, we see a circular opacity here. All these vessels are thick because this patient has congestion. So we go out onto the CT scan, sort of a sagittal cut that goes with that radiograph at a level out here. This is pulmonary artery there, actually the interlobar pulmonary artery. In front of it, it's the pulmonary vein. This is the right upper pulmonary vein. Together, out laterally enough, they're surrounded enough by lung that they make a circle on the lateral radiograph, like this. Here's a 40-year-old female with a large secundum atrial septal defect. Here's a 4-chamber CT scan, left atrium, left ventricle, right atrium, right ventricle. The right ventricle is big, right atrium is big. This is a defect. This is a secundum atrial septal defect. And it's causing volume overload. So out here, we see this big circular opacity. We can go to a lateral sagittal on the CT scan to see what makes this. This is the interlobar pulmonary artery and truncus anterior. This is the bifurcation of the right pulmonary artery, and this is the right pulmonary vein sitting in front of them. The lateral opacity is made by the interlobar pulmonary artery and the truncus anterior. Those are branches of the right pulmonary artery. It bifurcates superiorly, inferiorly, and the right upper pulmonary vein. All that together is making this, which you can see is the level right out here, makes that opacity on a lateral radiograph in this patient. And this is her frontal radiograph. Okay, so that's what lives there. How about here? We kind of touched on this before. The left pulmonary artery goes over the left bronchus, right? The left pulmonary artery runs over the left main stem bronchus. And it's not going to usually show up on a lateral unless it's abnormal, but we can see where it lives here on this patient. As we peel away to the lateral, and we're going to slowly peel away. Here's our heart beating. This is the descending thoracic aorta coming over. There's our aortic arch. Here's our RV outflow, and there's our main pulmonary artery. The right pulmonary artery is running left to right in the plane that we can't see, but this guy right here is our left pulmonary artery making sort of an arch. So the left pulmonary artery runs more anterior and posterior than the right pulmonary artery, like that. And you can see it runs roughly parallel in a plane, in a direction roughly parallel to the aortic arch, just a little more inferior. And note that the left superior pulmonary vein runs anterior to the left pulmonary artery. So there's our pulmonary vein. It's a little hard to separate, but our pulmonary veins are here, and this is our left pulmonary artery. If we tilt our point of view a little bit, it'll be a little clearer. Here's the aortic arch. Our right pulmonary artery is going to disappear under the aortic arch, and there's our left pulmonary artery. It also runs roughly parallel but inferior to the level of the aortic arch. Like that. It runs mostly in the anterior posterior plane in an anterior posterior direction, and it passes superior to the left main bronchus. And the left superior vein runs anterior. So this stuff here is the left superior pulmonary vein. And we're going to get into the pulmonary veins a little more later. So if we rotate down, so we're going to look more from the front. Here's the right ventricle sitting out in front. This is the right coronary artery. This is the right atrium. There's the aorta, and there's our main pulmonary artery. The left pulmonary artery runs more front to back. The right pulmonary artery runs more right to left in the mediastinum. and we fill in frontal radiograph. Okay, so here's someone who's abnormal. This is a 66-year-old female. She has pulmonary valve stenosis. Now, pulmonary valve stenosis disproportionately enlarges the left pulmonary artery compared to the right, because the left pulmonary artery is more in line with main pulmonary artery flow. So this is an axial CT scan from the same patient. And you can see that if there's pulmonary stenosis, pulmonic valve stenosis here, it makes a jet. And because the left pulmonary artery runs front to back, it preferentially enlarges the left pulmonary artery as opposed to the right pulmonary artery. And it's this line here. So I'm going to show it again, but see this contour here is the pulmonary artery, and where this is the aortic arch. So there's the left pulmonary artery outline, and there's the aortic arch outline. And if we go to the CT scan in this patient, and we peel away, you can see there's the left pulmonary artery. Behind it and a little higher than it's the aortic arch. And there's the enlarged left pulmonary artery. And it's larger than the patient's aortic arch. If we tilt, so we kind of look from the side, you can compare them a little bit better. And then we'll go down to the front. We fill in and put the frontal radiograph. This is entire large left pulmonary artery. That's what pulmonary valve stenosis is kind of famous for, preferentially enlarging the left pulmonary artery as opposed to the right. Here's a different patient. This patient is a left pulmonary artery stent that shows up very well. Just going to highlight it there. And the reason I'm just mentioning that is to show that the left pulmonary artery stent runs front to back on the frontal radiograph, on the lateral radiograph, to emphasize that that's where the left pulmonary artery normally lives. Okay, that's the left pulmonary artery. Down here, the pulmonary veins, we kind of referred to them a little bit. So you notice that the mitral valve is pointed along the cardiac axis. So here's an axial CT scan, left atrium, left ventricle. The mitral valve kind of points that way. You can see the axis of the heart is tilted to the left, and it's actually tilted to the left and down, like that. So the mitral valve kind of points at the LV apex, which is usually to the left. But the pulmonary veins come in from the right and the left. The pulmonary veins merge into the left atrium. They kind of grow embryologically from the lungs and merge in. And so they're kind of more in line with the axis of the body and the lungs, as opposed to the axis of the heart, which has this left tilt. So embryologically, the pulmonary veins go in from the lungs and merge from the heart. As a result, the left and right pulmonary veins usually overlap on a lateral chest X-ray. So the point of that is that these pulmonary veins are going to be at the same level, left to right. The superior pulmonary veins are more anterior. The inferior pulmonary veins run more kind of in the plane. They're not tilted this way, which they would be if they kind of which they probably would be if they embryologically came from the heart. So the upper pulmonary veins come in from anterior, and they run anterior to the respective pulmonary arteries. We've seen that in a couple of times. Mentioned that with the interlobar pulmonary artery, mentioned it with the left pulmonary artery. The lower pulmonary veins come in from the posterior, like that, like so, and makes this kind of little shape. So if we go to the CT scan in this patient, here's our left pulmonary artery, and in front here, this is left upper pulmonary vein, left lower pulmonary vein. The left upper pulmonary vein comes from the top, runs in front of its pulmonary artery and merges in. The left pulmonary vein runs kind of from the back and posterior, and they kind of make that shape. These are the left sides, because that's where we've been looking from the left side. There's the left upper pulmonary vein, the left lower pulmonary vein. So if we rotate around to the front, now we're looking from the front, and then we're going to rotate around and look at the right side. Here's the right atrium, right atrial appendage. This is the right coronary artery. This is the aorta. This is the SVC. And there's the right lower pulmonary vein and the right upper pulmonary vein. And we'll flip it around to look from the right side, and there's back to our lateral radiograph. Okay, now we have a 55-year-old female, the history of atrial fibrillation, status post-pulmonary vein isolation. That's a treatment done to keep the electrical activity that's coming from the region of the pulmonary veins away from the left atrium. One complication of that can be stenosis of the pulmonary veins, which she got. And so she wound up getting 4 pulmonary vein stents, which are here. See them there? And again, the reason for showing this is to emphasize that this is the normal anatomy of the pulmonary veins. If I show you a case with stents in the veins, then you can see them on the radiograph. We can then overlay the CT, and it also shows up pretty well. Left atrial appendage, left ventricle, right ventricle, right, the main pulmonary artery. And if we sort of window down and take away some of the soft tissue, you can see the pulmonary venous stents back here, right there. We're going to rotate around from the back. You can see the pulmonary venous stents running the way you said, with the upper pulmonary veins kind of running anterior to their pulmonary arteries and the lower ones coming in from posterior. Rotate around to the right, and you can see it again to the front. Filling in a little bit, back to the frontal radiograph. So there are those pulmonary venous stents. This is just to emphasize that that's the normal location of the pulmonary veins. All right, so 68-year-old male, normal pulmonary veins. This opacity that we're showing with the arrows is made of the lower pulmonary artery and veins overlapping. If you kind of look at lateral radiographs, you're going to see some lines, some streaky lines that come through here, which is the overlap of the pulmonary arteries and veins. And I'll just show you the CT scan just to show what's causing that. This is pulmonary artery. Back here is pulmonary veins. See, here's pulmonary veins, pulmonary arteries. Different patient, 69-year-old female, and atrial fibrillation. So in this patient, all the pulmonary veins are engorged because of congestion. And so there's a pulmonary vein here, upper pulmonary vein, fat, left lower pulmonary vein, and here's the pulmonary arteries. A large inferior pulmonary vein points towards the left. There it is. Frontal radiograph. Here's a 64-year-old female. There's overlap of lower pulmonary arteries and veins down there, and I'll just show you what's making that. Again, here's the pulmonary arteries. Behind there, this is pulmonary veins. If we peel away a little bit, makes it a little clearer. Here's pulmonary veins. So if you pay attention to the hilum, again, we have the trachea, right upper lobe, left lower lobe. We have this opacity here from the interlobular pulmonary artery and the right upper pulmonary vein. And then these lines here, if you start paying attention, this is overlapping of pulmonary arteries and veins. There's some other structures in here that we're going to get to later. Different patient, 47-year-old female. Is there too much soft tissue in this area? If we peel away, we can see that there's all these darker blobs. This is mediastinal and hilar adenopathy. This patient had sarcoidosis, and again, you can see these lymph nodes. And there's the axial CT scan showing the mediastinal and hilar adenopathy. Frontal coronal slice shows mediastinal and hilar adenopathy. So this patient had sarcoidosis. So we move on from the pulmonary veins to the esophagus. And if we peel away here from our patient, here's the aorta. We're going to keep peeling away a little bit more. We go kind of to the midline into a thin slice. This structure, stringy structure, is the esophagus. It's right there. And we're going to another midline picture. The esophagus is near the left atrium. So this is the left atrium. This is the right pulmonary artery. This is the ascending aorta, and this is the esophagus. And you can see, if you can imagine, if you put an ultrasound probe down here and you looked from here, you'd get a good picture of the left atrium and the rest of the heart. This is what we call Trans-Esophageal Echocardiography. So imagine here's a CT scan. If we had and here's the esophagus. If we had to put a probe right there, A trans-esophageal probe, it would look through the left atrium. We get a picture like that, where this near field is the left atrium. In this case, this is the left ventricle, the mitral valve. And the trans-esophageal probe, if it's in the esophagus and hasn't perforated, always has the left atrium in the near field. So you imagine here's our CT scan. If we had a probe right here, we can make a view like that. This is just to emphasize that the esophagus runs posterior to the left atrium normally. Fill it in. And you can see the esophagus runs up by the trachea. Superiorly, it's between the trachea and the spine. We kind of mentioned that previously. Esophagus may be slightly to the left or the right. Again, you can't tell on a radiograph, but you can see that on a CT scan. In this patient, there's also subcarinal lymph nodes adjacent to the esophagus, following the level of esophagus on the lateral radiograph. More inferiorly, the esophagus will remain closer to the posterior wall of the left atrium, so it's going to start to move kind of more. It's going to follow the soft tissue and kind of move more anteriorly. And the esophagus goes to the diaphragm anterior to the spine, posterior to the left atrium, about there in most people. And most people, you won't see it on a lateral radiograph. This is a 61-year-old female who had esophageal cancer. She had an esophageal stent. So the stent that we see on that radiograph is in the esophagus. We peel away on the CT scan and look laterally. You can see that big stent. It sits posterior to the left atrium. This is where the esophagus sits. In this case, it's stented. Left atrium, ascending aorta, right pulmonary artery, descending thoracic aorta. We rotate around to the front. You can see that stent posterior to the left atrium. We fill in. Put the radiograph back there. There's our esophageal stent. Different patient, 73-year-old male. We have a soft tissue density here with an air fluid level. We go to the CT scan. We can see this is an esophageal hiatal hernia. Some of the stomach is up into the thorax, and that's what's making that air fluid level on the lateral radiograph. It's a pretty common finding. You can see it on the frontal radiograph here. There's a soft tissue. There's an air fluid level. Different patient. Now we see an air fluid level way up here. We see multiple lucencies here in the posterior part of the radiograph. We see anterior displacement of the trachea. We see an additional air fluid level down here. We look at the CT scan, what's going on. What do we have here? We have achalasia, which is it's a condition that gives you a super dilated esophagus. So this is esophagus, and it causes anterior bowing of the trachea. And note that the air fluid level has changed in orientation from the radiograph to the CT scan, because the CT scan is done with the patient prone, so our air fluid level goes this way. The radiograph is done with the patient upright, so our air fluid level on the radiograph goes horizontally that way. This is a frontal. This loop there causes the more inferior air fluid level we saw in the lateral radiograph. If we fill in there, this is all dilated esophagus. There's our air fluid level there. This patchy lucencies is air and food in the esophagus. All right, we move on. That little contour is normally the left atrium. So if we peel away, we see the left ventricle here. This is the left anterior coronary descending, the LAD, the left anterior descending coronary artery. And oops, that was too fast. We rotate around a little bit off to the lateral, and there's the left ventricle and left atrium. See the left atrium beating there. Because the heart points anterior and to the left, puts the left atrium posterior, so it's right in front of the spine. So if the whole ventricle pointed front to back, then the left atrium would be sit off that way. But because the left ventricle points to the left, it puts the left atrium posterior. In most people, but not so much this patient, the LV apex kind of points down and to the left, And that contributes to the left atrium being a little bit up higher. And here's our esophagus. The left atrium sits a little bit higher to the contour of the left ventricle. If we're going to rotate around, now we're looking from the back. Here's the left atrium. Here are pulmonary veins. This is descending thoracic aorta. The left atrium is posterior, and because it's slightly superior, there's a clear space that lives about here on a lateral chest X-ray. We're going to rotate around to the side, back to the front and fill in. And there's our frontal radiograph. So the left atrium is posterior, slightly superior to the left ventricle. That creates a clear space that lives here in most people. Okay, here's a different patient, 69-year-old female with atrial fibrillation. That contour there is, if we peel away on her, this is all left atrium here. This is the coronary sinus. This is left atrium. If we overlay a transthoracic echo, this is an echo. Left is left atrium, left ventricle, aortic outflow. The left atrial volume index in this patient was 101 milliliters per meter squared, where severe is greater than 48 milliliters per meter squared. So this is a big, very big left atrium. We're going to come around to the front. Different patient now. We have a 70-year-old female. And we can see that there's a circular calcification here. It's all round. Patient has large pleural effusions. And if we go to see what is causing that circular calcification, this is hard to see. This chest CT was done without IV contrast, so we don't see the left ventricle and all those structures very well. But this is all calcium in the ascending aorta. This is calcium in the descending thoracic aorta. This round ball is calcified left atrium. Calcified wall of the left atrium. And here on this axial slice, you can see the calcified left atrium, left ventricle, right atrium, right ventricle. This is sometimes called porcelain atrium or coconut atrium. It's most associated with rheumatic heart disease, as in this patient. It's been described as occurring in renal insufficiency. And note this patient also has dense calcification in the ascending aorta and descending thoracic aorta, which I just mentioned. And there's also dense calcifications in the trachea. There's also calcification in the mitral annulus there, which is this stuff, mitral annular calcification. So there's the left atrium. Right there is where the left ventricle normally lives. So if you can see it, imagine it's sort of like a football. And because the apex is pointed down and to the left, this border, you can see a little border that it makes right there. If we go to the CT scan, you can see the left ventricle here. There's the apex of the left ventricle. It's pointing sort of toward us in this image. This is the LAD, the coronary artery that runs in the groove between the left ventricle and the right ventricle. This is the apex of the heart. This is a different patient. This is a 59-year-old female with a history of mitral prolapse and mitral valve regurgitation. She's had a mitral valve repair. So this is a mitral valve annuloplasty band. This is showing us where the mitral valve lives, which is a pretty helpful landmark in this patient. So that curve there, we see that this is too prominent. That's not normal. And this mitral valve annuloplasty band shows the border between the left atrium and the left ventricle, which is going to be helpful here. This shape is showing us the border of the left atrium in this patient, which is actually not enlarged. And there's an overlaid 3D model of the left atrium there. This contour is made by the left ventricle in this patient, which is going to be about there. So this is the left ventricle. I'm sort of got a 3D model. There's the left ventricle. right ventricle, left atrial appendage, and the left atrium is living back there. We kind of ghosted out, put the 3D on there, and you can see that that border really was made by the left ventricle. The left atrium is sitting posterior behind here. You can rotate around to the front. Sternotomy wires are from the mitral valve repair. We put the frontal radiograph on there with our mitral valve annuloplasty band. Different patient. Again, look at all these structures that we've seen before. Trachea, right upper lobe, left upper lobe. We're going to get to the aortic arch later. The left atrium should be here, but we've got this big bulge there. It's a little bit lower than the level of the left atrium. And in a lot of patients, and I'll get to this later, left atrium and left ventricle can both be enlarged. But in this patient, this is a 68-year-old female with ischemic cardiomyopathy. This bulge is left ventricle. And this prominent contour is in the expected location of the LV lateral wall. Here's a couple pictures from an LV gram. So there's a catheter, pigtail catheter right there. It goes from the descending thoracic aorta through the aortic arch. It's in the left ventricle. And you can see that this bulge here is the LV lateral wall. It kind of is pooching out more than expected. And that's from this left ventricular gram, LV gram. This is an image from a cardiac MRI. And you can see that there's thinning and bulging of the left ventricular wall there, which is causing that contour on the chest X-ray. And then we can also overlay an FDG PET scan. This is PET perfusion showing that this area has got absent perfusion. This is an infarcted area, which is why it's bulging. Notice the perfusion defect is at the site of LV dilatation. We go to the frontal, and that LV enlargement isn't as prominent here as it is on the lateral. It's not as well seen on the frontal radiograph. This is because this person's infarct was localized to the inferolateral wall, which is there. Here's our FDG PET scan showing the contour of the left ventricle on this frontal radiograph. Different patient, 57-year-old male with dilated cardiomyopathy. And in many patients, as in this patient, enlargement of the left atrium and enlargement of the left ventricle coexist, and they're both present and they overlap. So you get this just one big contour back in the back, and you can't separate them out. All right. Different patient, still talking about the left ventricle. Here's an 80-year-old male. What is that line? Still talking about the left ventricle. If we go to the CT scan and peel away, we can see that that line, this white stuff here, which is a calcified infarct at the LV apex right there. And there's a two-chamber view from the same CT scan. We can see that this calcium there is thinned out. This is an old infarct, which is calcified, and it's dense enough, and it shows up on the lateral radiograph. We rotate around to the front. We can see it here too. It doesn't show up quite as well. That's right there. Different patient, 76-year-old male, prior coronary artery bypass grafting. What's this line here? Not as prominent as the prior one, but it's there. We go to the CT scan again. We can see that this is also calcified infarct at the LV apex. So this one is thinner calcification. All of the stuff inside or deep on the inside, the endocardial surface of the left ventricle is all thrombus there, which you don't see on the lateral radiograph. But the point is there's a little thin rim of calcification there. And there's the front. That's too fast. Let's go. We'll rotate nicely. Rotate nicely. There's the infarct. We can fill it in. And it doesn't show up so well on the frontal radiograph. So that was the left ventricle. Let's move on to the next thing, which is going to be the pericardium. Now the pericardium covers a big area. Let's get to that. So anyway, the normal pericardium, I'm just going to get to this. It goes from the level of the ascending aorta, wraps around all the way back here, it makes a sac with one layer, an inner layer super adherent to the epicardial surface of the fat and the micro, and then another layer which is outside. And that pericardial space and the pericardial tissue can get lots of problems, and we'll look at one of them. So here's a patient. We have this thick calcified line, and it looks a little bit like the calcified line we just saw for that Levy infarct, but it's a little different. What's this line? First thing you notice is this extends beyond the expected border of the left ventricle. We already showed before that the left ventricle makes sort of a football shape that lives here, but this pericardial space goes, pericardium, all this calcified, I just gave it, this calcification goes up all the way up there. We go to our lateral CT scan and peel away. You can see that all this calcified stuff is not really in the left ventricle or the right ventricle. It's on this tissue layer outside. This is calcified pericardium. Calcified pericardium. Note how the pericardium extends over the proximal ascending aorta and the pulmonary arteries, like that. Like that. At this level on this CT scan, this is from the same CT scan. There's the main and right pulmonary artery, ascending aorta. We're talking about a level up here, and we see these calcifications. The pericardium goes up pretty high over the great vessels, not just the heart proper. This space between there, this little empty space here between the myocardium and the pericardium, epicardial fat. It's this fat that fills the space here. This fat is between the myocardium and the visceral pericardium. So the pericardium is two layers, and the layer that's closely adherent actually adheres to this epicardial fat. I don't know, I used to think it adhered directly to the myocardial surface, but if there's fat on the surface, the visceral pericardium adheres there. The parietal pericardium is outside, and if you get fluid between there, the fluid will fill up in this space. We'll get to that. Anyway, that fat there can be pretty helpful in detecting pericardial abnormalities, especially pericardial effusions, which we'll get to in a second. We roll around to the front. You can see this calcification is over the right ventricle, over the right atrium. We fill in on the frontal radiograph. You can get hints of it, though sometimes it doesn't show up as well as on the lateral radiograph. Different patient, same idea. Here's this line. Calcifications go beyond the expected border of the left ventricle. If we go to the CT scan, you can see these calcifications are sitting out here over the ascending aorta, over the lateral wall of the left ventricle. This is pericardial calcification. Oops, that was too fast. Sorry, we got to do the full rotation here. It's over the ascending aorta, over the right atrioventricular groove, over the Rv outflow. So this is pericardial calcification. Okay, different patient. This is an 83-year-old male who had recently placed a biventricular pacemaker. Now, in case you don't know, a biventricular pacemaker is supposed to have one lead in the right ventricle for pacing the right ventricle, and another lead goes in a vein, usually goes through the coronary sinus and goes through into a vein that's usually on the surface of the left ventricle, and that's for pacing the left ventricle. So what do we have here? Our left ventricular pacer is not capturing thresholds. And so let's look. We have a right atrial lead, which is there. That's normal. And a right ventricular lead, which is kind of thick, lets you know it's a defibrillator, which is there. And I will tell you that there's another lead here, which is supposed to be in an epicardial vein. And these epicardial veins typically run up here, not down by the apex. This guy is supposed to be pacing the left ventricle, and this lead is not capturing. Now notice this dark line here, right there. We have white on one side of it, white on the other, and there's a dark line in between. What causes these lines? Let's look at the CT scan. We have this non-contrast CT scan, and we're going to peel away, and what do we see? We see this pacemaker lead here, the one that was down at the tip that's supposed to be in an epicardial vein is in the pericardial space. This is a coronary calcium. If we rotate this guy Oh, I'm sorry, we'll get to that in a second. This epicardial fat here causes the dark area on the chest x-ray. And this is what I was getting to before. The epicardial fat is here, the visceral pericardium sits there, and the parietal pericardium is up there. Pericardial effusions form. They're going to be superficial to this epicardial fat, which causes a dark line on this lateral chest x-ray. So there's pericardial effusion, there's heart, and epicardial fat sandwiched between the pericardial fluid and the heart causes the white, dark white on the lateral chest x-ray, like that. Now, if we rotate this up into a sort of a semi-four chamber plane, we can clearly see this pacemaker is in the in the pericardial space. It's sitting in the pericardial space. If we rotate around to the front, this is the lead that we want. It's not where it's supposed to be. It's supposed to be in a vein up here. It's in the pericardial space. This is a calcified coronary artery. This is part of the lead in the right ventricle. This is part of the right atrial lead. We peel it away, we can see the right ventricular lead. Now, the reason it looks kind of broad is because of motion on the CT scan has blurred it out. This actually should be more, not a flat, broad, looking like a flat ribbon, but it's actually a tube. There's the right atrial lead, also kind of blurry, but anyway, here's right ventricular lead, right atrial lead, and this guy is in the pericardial space. And if we fill in the tissue again, we can overlay the chest x-ray and you can see all that stuff. So here's the right ventricular lead, right atrial lead. This is supposed to be in an epicardial vein. It's not. I think you can get a hint of the coronary calcium too. Different patient, 69-year-old male with ischemic cardiomyopathy. Here's a right atrial lead. Here's a right ventricular lead number 1, right ventricular lead number 2. Those are all fine. I'm just going to point them out to you because they're there, and so you don't get confused. That's not going to be the point here. But are there 2 lines here? Can you see that? If we highlight them a little bit, you'll see them better. Is there a dark strip between? See, 2 lines. Line here, dark strip between, and notice all this sort of structure here. This looks pretty organized and regular. You can sort of see it down here too. What is going on here? What's causing this? If we go to the CT scan in the same patient and we peel away, we can see this man-made sort of interlocking structure. This is a pericardial mesh. This is a man-made device that was placed outside the pericardium to contain the ventricles. This other line here is a calcified infarct. So this is a cardiac restraint device. These were developed with the idea that to prevent dilatation of ventricles, like prevent dilatation in dilated cardiomyopathy, and they didn't really work and they're not used nowadays. But here is a photograph of this mesh device on a model. This mesh is what we're seeing is making the outer line. This infarct makes the inner line. So there's the inner line of the infarct, the outer line of the mesh on the lateral radiograph. The space between there is the epicardial fat. So there's the epicardial fat. There's the infarct. And this dotted line there is the mesh. Here's the infarct. There's some thrombus. This is mesh. And between there's epicardial fat. If we rotate around, you get a little bit better view of this mesh, how it's sort of placed. You can imagine it was sort of slipped over the left ventricle and right ventricular from the apex. And it's intended to prevent dilatation. We'll go back to the frontal and fill it in. If you look carefully, you can sort of see the texture there too. Okay. Here's a 63-year-old female who presented to the emergency department with stroke symptoms, and we don't have a chest x-ray. She just went straight to CT scan. So we have this scout radiograph from her CT scan. So this isn't a radiograph, this is a scout image from a CT scan. Okay. So you notice this internal jugular venous catheter, it runs like that. Okay, and that's too low. These catheters are supposed to be in the SVC or the right atrium. This was too low. And it was used for a contrast injection. Now, the tip of this was either slightly perforated or right up in the wall of the right atrium, because what happened was this contrast injection didn't go into her right atrial cavity, into the blood volume. It was direct contrast injection to the pericardium. Here's an axial image from the CT scan. This is intended to be with IV, intravenous contrast, but you can see there's no contrast in the blood pool. It's all intrapericardial. Now, we don't have a radiograph. And again, this wasn't her most important. Once she got this, she became hypotensive and this had to be taken care of quickly. But for the purpose of this discussion, I'll just show you, we can reformat the CT scan to show what a radiograph with the contrast in place might have looked like. Now, when you rapidly fill the pericardial space with fluid, the heart can't compensate. People get hypotensive and unstable. She had to have this emergently evacuated. But if she had been stable enough to have a radiograph, this is what it might have looked like. And this is what the lateral might have looked like. This is a sagittal slice from a CT scan, and you can see this white stuff is contrast in the pericardial space, and you can also get appreciation for all the different pericardial recesses that there are. If we look at the 3D, it's actually not that much to see, because the pericardial sac, as it covers the entire heart and the origin of the great vessels, and it's so dense with contrast, we can't see it, looks like a big white sac. If we rotate this over to a short axis view, we can overlay an echo that she got sort of emergently. And this is a short axis echo with a left ventricle and right ventricle and short axis. And this is all pericardial fluid with some bubbles. This is contrast. Now, here, I'll just go back a bit. I just show you that the contrast here was sort of inferior, where here the contrast is more, anterior. It's because she was in a different position when this echo was taken as opposed to when the CT scan was performed, but you get the idea. If we rotate back around to the front, you can see all this fluid in this pericardial spaces, and we can fill in and go back to our semi-frontal radiograph. Well, that's the pericardium. Next, RV outflow. So if we look for the RV outflow, you can see that the right ventricle sits the most anteriorly in most people. And it's right there. In adults with normal sized right ventricles, you usually get a clear space in here on the chest X-ray, about here, but not so much in this patient. This patient, because there's no clear space because of body habitus. What if we get somebody else who's a little thinner? We can see this well-defined clear space where there's the right ventricle, sits out anterior. This is the LAD. This is left ventricle, and the right ventricle makes the anterior heart border. We rotate around to the front. You can see how the right ventricle sits out in front. And we fill in for the frontal radiograph on that patient. This is a different patient. This is the RV outflow tract lives there. This patient this is a 73-year-old male with carcinoid. So carcinoid gives you, if it's in the bowel and the liver, and you get liver mets, you get the chemicals that damage the tricuspid valve and the pulmonic valves. They come in from the right side of the heart. So he's got a bioprosthetic tricuspid valve, a bioprosthetic pulmonic valve. We're going to emphasize the pulmonic valve because it helps show, and there's a tricuspid valve. This will help show where the right ventricle lives on this lateral radiograph. Tricuspid valve, pulmonic valve. And if we fill in the CT scan, we can see how the right ventricle lives out here in front. There's the right ventricle, tricuspid valve, pulmonic valve. This is the pacemaker going in through the SVC into the right ventricular apex. We rotate around, tricuspid valve, pulmonic valve, fill in soft tissue. Here's right ventricle, pulmonic valve, and here's frontal radiograph. And there is tricuspid valve, pulmonic valve. Rvl flow. Next, we're going to talk about the aorta. So if we peel away, and we've been talking about it and seeing it in the background in a lot of these cases, here's the ascending aorta. It kind of comes around here, loops around the right ventricle, the pulmonary artery, the main pulmonary artery, arches over and comes back down on the left side. So this is easier to see in more people with more clear space. So this person has more clear space than our sample person, and you can see the ascending aorta contour right there, the aortic arch and the descending thoracic aorta. 64-year-old female. There's the aorta. We can fill in. Again, you can see the aorta. You can see how this contour makes the aorta in this normal person, and we can fill in the aorta by itself, the rest of the mediastinum, and we'll rotate to the front and then fill in frontal radiograph. Different patient, 80-year-old male, bioprosthetic aortic valve replacement. This is the aortic valve right there. This helps show where the aortic root is. It'll point us to the ascending aorta. This is what this bioprosthetic valve looks like in this patient. It's got these struts which hold the tissue, and these little markers which are there. We see a clip at the origin of a bypass graft. So this person has a saphenous vein which has been attached to the proximal ascending aorta, and it's going to plug into a coronary artery. And that's a nice marker where the ascending aorta is in this patient. This is going to help show where the ascending aorta is. The ascending aorta margin is visible here. And we can see calcium. It helps show where the descending thoracic aorta is here. And then that's where the aorta is in this patient. And then we can overlay what we have of the aorta from the CT scan. You can see the beating heart where we see these calcified coronary arteries. We can see the prosthetic valve. And we can rotate around to the front. This is a calcified coronary artery. We can fill in the tissues. We'll see the left ventricle fill in, then we see the right ventricle fill in. We put the frontal radiograph on top of it. 66-year-old male. He presents with a cough. All of that is gigantic. That's a gigantic ascending or gigantic thoracic aorta. There's a big aneurysm, mostly of the descending thoracic aorta. Aneurysm, the ascending and descending thoracic aorta. Here's an axial slice CT scan. There's the ascending aorta. There's the descending thoracic aorta. We rotate around the front. You can see that you can see the whole bulgy contour of the thoracic aorta. So this is a stent for treating the descending thoracic aorta. This person's got a ascending aortic bypass graft. This is all bypass. This is graft material. These are grafts to the great arteries. This is a stent in the descending thoracic aorta. Surgical replacement of the aortic root. Total arch replacement, surgical, stent. That's the same patient. You can see the outline of where the aneurysm sac is and the descending thoracic aortic stent on the radiograph. So that is all the lateral mediastinal anatomy. I want to thank you guys so much. Hope you have a good one. And that's it. Thanks a lot. Bye.